Schizophrenia and the other psychotic disorders are some of the most impairing forms of psychopathologies and have some of the strongest negative effects on people's life outcomes. These disorders often show up in young adulthood. And when we talk about a spectrum of psychotic disorders, this would include schizophrenia as well as schizoaffective disorder, delusional disorder, schizotypal personality disorder, schizophreniform disorder, and others. So primarily, I'm going to be talking about the clinical features of these disorders, focusing for the most part on schizophrenia. And so for an overview of this part, it's just understanding what schizophrenia is. I'll review the cognitive limitations associated with schizophrenia as well as risk factors for developing schizophrenia. After hearing this part of the lecture, I hope that you'll be able to describe the signs and symptoms of schizophrenia as well as the related psychotic disorders. Describe the most well-replicated cognitive and neurobiological changes associated with schizophrenia, and then describe the potential risk factors. So one of the characteristic features of schizophrenia is the experience of delusions. Delusions are false beliefs that are often fixed. That is, they're hard to change even when the person is presented with conflicting information. They're often culturally influenced as well. So, for instance, somebody that is having a delusion might believe that there's somebody like Jesus Christ, as a for example, if they grew up in a Judeo-Christian culture. Alternatively, another delusion might be something like the person believes that they're a secret operative working for the like the CIA or the government. Okay, so there's some the delusions come from some world knowledge or some cultural knowledge, but at their heart, they're false beliefs. So these can, of course, be very scary for the person that has these delusions. The person remains convinced that what they believe is true, even when loved ones and friends present very clear information that the delusion can't be true. And so there's many different types and themes to delusions, which I'll go over in the next slide. Pictured in this slide is a self-portrait painted by an individual who was diagnosed with schizophrenia. It reflects, in part, the distorted perception, it kind of in the way that this person felt like they were being controlled by outside forces. Okay, that they're having delusions of being controlled by outside forces, and so you can kind of see this art image of being hooked up to this outside machine. Okay, so there are a couple different types of delusions. Specifically, there's four, and I want to review these four main types that are commonly found in people suffering from schizophrenia. So the first type are known as persecutory delusions. In other words, the belief of feeling persecuted. And these persecutory delusions are some of the most common delusions. So they would involve, for example, the belief that individuals or groups are trying to hurt, harm, or plot against the person in some way. So these could be people that the person knows. For instance, my neighbors are spying on me. These could be people at work, like my coworkers, are trying to sabotage my work products. It could even be family members, okay? But it could be also like more abstract groups or groups that the person doesn't know well, okay? So like the FBI, the government, even like aliens. Aliens are spying on me. But it's the person believes that they're being persecuted in some way, that there's other people or groups that are out there trying to do them harm. Okay, the next type of delusions would be delusions of grandiosity or of grandeur, or grandiose delusions. This is when a person believes that they have some type of special power or ability. So they might believe that they're, the second coming of Christ. They might believe that they're spiritual, like a Buddha. They have healing powers. They might just believe that they're a rock star or something like that, or that they have superpowers. So they have these very, very inflated and unrealistic sense of their abilities, such that they believe that they have special powers. Um, the third type is referential. So with referential delusions, this is when a person believes that events or objects in the environment have special meaning for them. Okay? So for example, they might hear a song on the radio and believe that the musical artist wrote that song specifically for them, or that it's being played on the radio right now specifically for them to hear. Okay, so these are very self-referential uh, delusions, that when there's like events or things that happen in the world that are meant to take on special meaning for them and for them only. And then there's other types of delusions called thought insertion delusions, where a person may believe that others are controlling their thoughts and actions. Okay, so people are trying to control their mind. Um, one example of this is when people believe that their thoughts are being broadcast out loud, such that other people can hear their thoughts or read their mind. Okay, or alternatively, that they can read the minds of others. Okay. Okay, so those are delusions. Another very characteristic feature of schizophrenia is the experience of hallucinations. And often, um, if you see a person walking down the street and they're talking to themselves, or they're shouting, it appears to be another person, they're most likely experiencing a hallucination. And these are perceptual experiences that occur even when there's no stimulus in the outside world that is generating the experience. Um, Hallucinations, we often think of hallucinations as seeing things, as visual hallucinations, but they can also be auditory, that is hearing things. There can be olfactory hallucinations, so smelling things that aren't there, gustatory hallucinations, tasting weird things or things that aren't there, and then somatic, that is feeling things. So people might have a hallucination that there's things crawling on them, for example, and they can feel like spiders or insects on their skin. Um, I think, yes, let's go over the different types. Again, hallucinations can be auditory, visual, olfactory, gustatory, or somatic. The most common hallucinations, at least in adults, are auditory hallucinations. Okay, so again, even though we think of seeing things, or in this picture we've got the somatic hallucinations, the most common hallucination is are auditory. Auditory hallucinations can involve hearing voices, and they often involve these voices talking about the person having the hallucination. So sometimes the voices will comment on the person's behavior, or give them orders. Okay, so like tell them to do things. Very often the content of the hallucination is negative. So it might be like, what you did is stupid, you're a loser, even things like you should end your life. Sometimes these voices are a person that somebody knows, so they might hear the voice of a friend, they might hear a voice of a parent or a relative, or it can be a complete stranger. Sometimes the voices sound as though they're coming from outside the person's head. Sometimes they seem like they're coming from inside the person's head. But they're not experienced in the same way as a person's inner thoughts and inner speech. So it's not weird to like talk to yourself, and like we often think in kind of a narrative form, or it's not weird to talk to yourself, but when you hear a voice in your head that is clearly not your own voice, that is an auditory hallucination. All right, so auditory is the most common, and the content of the auditory hallucinations are very often negative. Okay, so other symptoms of schizophrenia include disorganized speech as well as disorganized behavior. Um, in terms of disorganized speech, talking to somebody with schizophrenia is sometimes very difficult. Their speech can be very difficult to follow, either because their answers don't clearly follow from your questions or because one sentence doesn't logically follow from another. And so this is referred to as disorganized speech. And it can be present even when the person is writing. And so in the picture on the left, you see a cloth that has been embroidered by somebody who has schizophrenia, and the disorganized thought pattern is evident even in the embroidered words, and acknowledge the way in which this disorganized thought pattern would likely manifest itself in the way that the person speaks. Okay, so again, a symptom is disorganized speech, and this is just when answers and sentences do not clearly or logically follow from one another. Another symptom would be disorganized behavior. So this would be behavior or even the way that a person dresses that is outside what we would consider normative for whatever culture they belong to. And so again, this could be like dressing in an odd way, maybe putting on makeup in an odd way, like painting lipstick outside of one's mouth. Engaging in unusual rituals like repetitive hand gestures or motions. It can also involve abnormal motor behavior like catatonia or catatonia. And so behaviors that seem to reflect a reduction, which is just, so when we're talking about catatonia, we're talking about behaviors that reflect a reduction in responsiveness to the external environment. And so people with schizophrenia or that demonstrate catatonia might hold unusual postures for long periods of time, as the person in the picture. They might not respond to verbal prompts from another person or even motor prompts like trying to move their body. Or they might engage in motor activity that is, movement patterns that don't have any purpose whatsoever. Okay, so both disorganized speech and disorganized behavior, also symptoms of schizophrenia. So far we've been talking about what are called positive symptoms, so delusions, hallucinations, disorganized speech, and disorganized behavior. And we call them positive symptoms not because they're good, but because the presence of these things, delusions, hallucinations, disorganized speech, etc., would be markers or symptoms of the disorder. But it turns out that some of the most debilitating symptoms of schizophrenia are often difficult to see. And so these include what we refer to as negative symptoms, because these are the absence of certain things that we typically expect most normal people to have. Okay, so negative symptoms are the absence of things. So, for example, there's anhedonia, or it's often, or we could talk about it as being also called amotivation. And so anhedonia or amotivation just reflects a lack of interest in the things that used to give a person pleasure. Okay, and so anhedonia, amotivation, we could also talk about a lack of interest or a lack of motivation, a lack of drive to engage in pleasurable activities, social activities, recreational activities. Okay, so what we're missing here is just it's a negative symptom because we're missing kind of the regular motivation to do things that are pleasurable, like seeing friends or doing our hobbies. Having anhedonia can result in a lot of time of physical immobility, and just again, it reflects this reduced drive or ability to take the necessary steps to engage in the things that the person once liked to do. Oh, sorry. There's amotivation. I was just talking about those kind of in a bundle. Okay, a loss of interest in the things that used to give pleasure, and a lack of drive to take the steps to do those pleasurable things. Okay. Another negative symptom is flat affect. Okay, so this is basically missing proper affect. So flat affect refers to a reduction in the display of emotions through facial expression, gesture, and speech information. So somebody with schizophrenia just doesn't have the normal facial expression or inflection in speech that signals emotion. They're just flat emotionally. Okay, and then there's alogia, which is a reduction in the amount of speech or increased pausing before initiating speech. Okay, so both of these, reduced speech, a lack of emotion, um, are again negative symptoms because it's kind of missing the normal things that normal people have. I've included here a link to a TED Talk, which is A Tale of Mental Illness by Ellen Sachs. This is a 15-minute video, and I highly recommend it. It's a very powerful video. Ellen Sachs is actually an accomplished professor of law and psychiatry at USC. She was diagnosed with chronic schizophrenia, and so she's managed to be a very successful professor, living her most of her adult life. I forget when she was diagnosed. I believe it was early in her as a young adult, and so she talks about what it's like to live with schizophrenia. She talks about what it's like to be admitted to psychiatric hospitals, to go through different psychotic episodes, and it's a really powerful video, and it really builds a lot of empathy for people that have schizophrenia. And I know personally it helped me understand as well, and get some insight into what psychiatric hospitals are like. And indeed, she's been an advocate for people that have psychiatric disorders in terms of changing policies in the way that hospitals treat people that are admitted with those types of diseases. So chances are, a very strong chance in fact, that there will be an extra credit question on the next exam that is about this TED Talk. So I highly recommend watching it. Okay, so when we think about the core symptoms of schizophrenia, we think about delusions and hallucinations. So people hear voices, they have false beliefs. However, problems in cognitive function are also an important part of psychiatric disorders and of schizophrenia in particular. And this is because there's a growing body of research that suggests that the cognitive problems in schizophrenia are really a major source of the disability and a person's loss of functional capacity. And when we say functional capacity, we're just talking about the ability to engage in self-care. Okay, so to be able to cook for oneself, to be able to clean, to be able to bathe, to be able to go to work, attend school, to have friendships and social relationships. So it can really be these cognitive impairments that create much of this diminished functional capacity. And so there's three areas in which people with schizophrenia experience cognitive problems. The first is with episodic memory. Recall from previous lectures that episodic memory is the ability to learn and retrieve new information about episodes in one's life. So our episodic memory is our memory for the episodes of our life. And so people with schizophrenia just aren't able to retrieve those. The second cognitive impairment is working memory. Working memory is the ability to maintain information over a short period of time, so like 30 seconds. So to be able to do, tasks that require your brain, and to be able to hold pieces of information in your brain for a short amount of time. And so, you can just think about the things that you do on a daily basis where you've got to remember things, and that could just be very simple things like adding up a string of digits, to just remembering somebody's name or an address before you can write it down, or store it someplace. So people with schizophrenia have diminished working memory capacity. Working memory is also responsible, or it's involved in tasks that involve controlling or regulating our behavior. So that can often mean like regulating. It can mean planning. That can mean being patient, and things like that. So regulating behavior. And then the third is processing speed. So this is the speed with which an individual can perceive auditory or visual information and respond to it. So people with schizophrenia are frequently slower than healthy individuals on almost all tasks that involve processing speed, which is really just to take information from the environment and act on it. Okay, so when somebody is talking to you, or you could think of like a boss at work giving some verbal instructions, you hear that verbal stimuli and it goes into your brain, and then you have a thought and you act on it, and then you either ask a question or you engage in a behavior, or whatever it is. So people with schizophrenia have slower processing speed. And then some people with schizophrenia also show deficits in social cognition. And it's, when we're talking about social cognition, this could include, for example, the recognition. Really, it's just social information, but specifically, we could be talking about the recognition of emotional expressions in the faces of other people. So it's unclear whether these deficits occur in social cognition, whether the deficits in social cognition occur from deficits in the previous three or something else. But people with schizophrenia show deficits in social cognition. And then, as the reading suggests, these cognitive deficits should be thought of as risk factors for schizophrenia, okay, and not necessarily a consequence, okay. And the reason is because these cognitive impairments reflect a part of the risk for the development of the psychosis, okay? So it's not that you have the psychosis and then the consequence of the psychosis is having these impairments. It's that people start to have these impairments, and that potentially leads to the onset of the psychosis associated with the schizophrenia. And so, again, these cognitive impairments can be thought of as precursors or risk factors. And some evidence that they should be thought of as risk factors is that these cognitive deficits, because these cognitive deficits are present prior to the onset of the illness, and then they're found usually in a milder form in the first degree relatives of people with schizophrenia. So that would be some evidence that there could be some biological or genetic basis for these cognitive impairments that then create a risk factor to then lead to schizophrenia. Okay, so neuroimaging techniques such as structural and functional magnetic resonance imaging, in other words, fMRI, as well as positron emission tomography, or a PET scan, have created the ability to understand the brain mechanisms that are involved when people experience symptoms of schizophrenia, including cognitive impairments. So, for example, a number of studies have suggested that delusions may be associated with problems in the salience detection mechanism, which are supported by a brain area called the ventral striatum. as well as the anterior prefrontal cortex. Basically, these are regions of the brain that normally increase their activity when something important, otherwise known as salient, happens in the environment. So if these brain regions misfire, it may lead individuals with psychosis to mistakenly attribute the importance to irrelevant or unconnected events. And so that could be part of the reason why people have these referential delusions, is that their brains aren't quite firing right in these areas. And there's kind of the typical salience or importance that a normal brain would place on different stimuli in the environment becomes magnified or increased among people with schizophrenia. There's also evidence that problems in working memory in schizophrenia are related to problems in an area of the brain called the dorsolateral prefrontal cortex. So these problems include changes in how the dorsolateral prefrontal cortex works when people are doing working memory or cognitive tasks, and problems with how this brain region is connected to other regions are important for working memory and cognitive control. So the short of it is really that without having to know those specific areas of the brain, what I would want you to extract is that there is evidence from brain imaging techniques that people with schizophrenia, their brains literally work differently than normal controls, and that they have these different patterns of brain activity, which could account for why they have the cognitive deficits, as well as some of the other positive symptoms like delusions. Okay, in terms of risk factors for schizophrenia, my animation is a little bit messed up. Let's talk about genetic risk factors. There is not, there is, beg your pardon, there is a clear genetic basis for developing schizophrenia. And researchers know this because there's consistent evidence from families, twins, and adoption studies that there's a biological basis for schizophrenia. With that being said, there is no schizophrenia gene. Okay, so what does it mean? There's no single gene that you can isolate and point to and say, if you have this gene, or if you have a marker on this particular gene, you will develop schizophrenia. It's likely instead that the risk for schizophrenia reflects the summation of many different genes, and each of these genes contributes something that kind of adds to the likelihood of developing schizophrenia or some other psychosis. It's very challenging to establish, while we know that there's a genetic basis, it's hard to identify specific genes because schizophrenia is a very heterogeneous disorder. And what is meant by heterogeneous is that two different people that are both diagnosed with schizophrenia might have very different symptoms. So for example, one person might have hallucinations and delusions, while the other has disorganized speech, as well as some of the negative symptoms like amotivation or flat affect. So it makes it very challenging to identify specific genes that are associated with a risk for developing schizophrenia when the disorder looks so different, even among people that have the same diagnosis. It's also the case that many studies now suggest that at least some of the genes potentially associated with schizophrenia are also associated with other mental health conditions, including bipolar, depression, and autism. So the same genes that can potentially be associated with schizophrenia are associated with other mental health conditions. All right. There's also environmental risk factors. Okay, so there's several on this list, but problems during pregnancy would be one. So, for example, problems during pregnancy would include when a mother undergoes increased stress, could have an infection, could be malnourished, or even diabetes. And so all of these things have been associated with an increased risk of than having a child that grows up to get diagnosed with schizophrenia. Complications at birth. So there can be complications which cause hypoxia, which is a lack of oxygen, and this has also been associated with an increased risk. Children who are born to older fathers have an increased risk of developing schizophrenia. And so when I say older fathers, I'm talking about middle-aged men, so in the 40s. I believe the research has been done with fathers who are 45. And it's not just schizophrenia, but older fathers are risk factors for a range of mental disorders, including bipolar, as well as autism. And I guess the theory is that it's often talked about women having a biological clock. Well, the theory is that men have a biological clock as well, because after a certain age, there start becoming random mutations in sperm. And it's these mutations in the sperm that can be a basis for developing these disorders. Okay. So in adolescence and then adulthood, cannabis use would be another risk factor. So cannabis use increases the risk for developing psychosis, especially if other risk factors are present. Living in an urban setting, so the likelihood of developing schizophrenia is higher for children who grow up in an urban setting. Also, being minority status. And so by that, I mean racial minority. And both of these factors together, so urban setting and minority status, might reflect higher social and environmental stress. It's ultimately these are what's called a neurodevelopmental factor. Okay, so when we talk about a neurodevelopmental factors, we're talking about processes that influence how the brain develops, either in utero or as the child is growing up. So growing up in a very stressful setting or situation because it's a stressful urban setting or being a racial minority could contribute to that. At least the research suggests. And it should be noted that on this list, none of these factors on its own is specific enough to be particularly useful. And it should be noted that you could have all of these risk factors and not develop schizophrenia. Okay, so much of the research is correlational, right? It's associative research. Is that people that are ultimately diagnosed with schizophrenia are more likely to have these factors than other people, but they're not determinative, meaning that you can have all of these and you'll never develop schizophrenia. So don't worry too much if you're noticing that several of those apply to you. Okay, so an important research area on the risk for developing schizophrenia has been to identify people who might be considered clinically high-risk people. And so these are people that show attenuated, which means milder symptoms of psychosis, and they've developed these symptoms recently, and they're experiencing some distress or disability associated with the symptoms. And so in order to identify these individuals, a new category of diagnosis called attenuated psychotic syndrome was added to the DSM. And so when people with these types of symptoms are followed, about 35% of them end up developing a psychotic disorder, most frequently schizophrenia. So it is somewhat controversial to add this diagnosis to the DSM because some clinicians worried that including these risk states would end up creating mental disorders where none existed. But the counter argument was that there's evidence that people that do have these high risk symptoms end up developing psychosis at a much higher rate than people with other types of psychiatric symptoms. And it's, if you can catch if you can catch the development of the disorder earlier on, then that allows for the possibility of intervention and treatment. And so, for example, there's some evidence that doing a non-invasive treatment, such as giving people omega-3 fatty acids or going through a family intervention, can help reduce the development of full-blown psychosis. So that's some arguments of maintaining this diagnosis in the DSM to try to catch people early. Okay, so earlier I referred to schizophrenia as well as schizophrenia spectrum disorders. So I've been describing schizophrenia for the most part, but here are the other types of disorders. And these are um, um, described in more detail in the reading. So please refer to your reading for a more detailed description of each of these disorders, but I'll go over them at a high level. So schizophreniform disorder would have the same symptoms as schizophrenia that are present for 1 month, but less than 6. So it's a shorter lasting disorder. Schizoaffective disorder would be symptoms of schizophrenia. And so when we're talking about symptoms, okay, again, we're talking about delusions, hallucinations, disordered speech, disordered behavior, as well as the negative symptoms, anhedonia, amotivation, flat affect, and allergia. Okay, so these are the symptoms that we're talking about. Okay, and so to have schizoaffective disorder, there's those symptoms as well as either major depressive episode or a manic episode. So I've previously lectured on what constitutes a major depressive episode as well as a manic episode when we talked about mood disorders. Delusional disorder would be experiencing delusions without the other symptoms of schizophrenia, so not necessarily hallucinations or disorganized speech behavior. There's having a brief psychotic disorder. There's some symptoms of schizophrenia that last for less than 1 month. And then on the previous slide, I had just referred to attenuated psychotic disorder, which is having these reduced forms of delusions, hallucinations, or disorganized speech. Okay, so these are all the spectrum of schizophrenia disorders. And again, please refer to the reading for a more specific description of each.